The case that I will be presenting is entitled Rapidly Progressing Anasarca, Diabetes, and Hypertension, Severe Cushing's from an Ectopic ACTH-Producing Tumor. The authors are myself, Dana Mueller, as well as Shanaz Siddiqui, Bassam Char, and Jomana Chaiban. Background on this topic. Ectopic ACTH-secreting tumors are an extremely rare cause of Cushing's disease, in which patients tend to present with rapid and severe manifestations of Cushing's, as well as markedly high levels of ACTH. The extreme hypercortisolism seen in these patients can be life-threatening and is considered an endocrine emergency, highlighting the importance of rapidly distinguishing this subset of patients. Treatment of this subset of patients needs to occur promptly, but at the same time tends to be complex because the management needs not only to be geared towards the life-threatening hypercortisolism, but also due to the underlying malignancy as well. This is a case of a 50-year-old female who had been referred by her primary care doctor due to new onset resistant hypertension, as well as swelling in the face and extremities, all which had occurred in the last 2 months. On primary evaluation of the patient, she showed many clinical manifestations of Cushing's syndrome, including diffuse anasarca, facial plethora, acanthosis nigricans, and supraclavicular fat pads. She was hypokalemic and hyperglycemic on laboratory evaluation, and she had a remarkably high morning and 24-hour cortisol level. Another key distinguishing aspect of this patient's lab work showed a markedly elevated ACTH level into the 700s. For reference, an ACTH level below 50 is considered normal, and with most endogenous producing tumors, it stays between the 200 to 300 range. Considering this extremely elevated ACTH level, there was high concern for an ectopic source of the tumor. Our patient underwent a PET CT scan of the chest, abdomen, and pelvis, which revealed a large hypermetabolic mass encompassing essentially the entire left hepatic lobe, as demonstrated in Figure 1A. Also, which was noted on the PET scan, was that both adrenal glands appeared hypermetabolic, which was consistent with severe hypercortisolism on lab work, and also with the bilateral involvement. This again suggested that it was likely an ACTH-dependent process instead of a primary adrenal. Ectopic ACTH-secreting tumors most commonly originate from the lungs, GI, and pancreas, while liver is more likely to be metastatic disease. For this reason, our patient underwent CT, chest, abdomen, and pelvis, which identified the likely primary source of our patient's tumor, which was pancreatic lesion as identified in the imaging as well. Management for our patient was particularly tricky for a multitude of reasons. First off, the cortisol level was so extremely high it was in the life-threatening range, and she was at risk for severe hypercortisolism consequences. For this reason, ketoconazole was used initially to reduce levels of cortisol. Ketoconazole failed to show any significant benefit in reducing serum levels for our patient, and because there was also the added possibility of hepatic toxicity due to the conjunction with the chemotherapy agents. For this reason, another agent, miterapone, was used and found to have a profound reduction in her cortisol levels from 139.5 to 41.7 within only 24 hours. More definitive management of the hypercortisolism was achieved with chemotherapy, and after 6 weeks of using carboplatin and etoposide, her cortisol levels had normalized. Again, this case is highlighting a case of severe hypercortisolism secondary to an ectopic endocrine ACTH-producing tumor, which requires prompt recognition and urgent treatment. Our patient's ACTH and cortisol levels were quite high, even for ectopic ACTH-producing tumors, and her symptoms were rapidly progressive, as expected with these types of tumors. Initial management focuses primarily on mitigating the life-threatening complications of hypercortisolism. However, it also needs to be balanced with the fact that a lot of these tumors have a mechanism called ACTH escape mechanism, where ketoconazole does not actually work very well because of the ACT overdrive. For this reason, our patient actually responded much better to a different therapy my terrebone. This case also highlights the fact that, this needs to be a multidisciplinary approach to these cases because they are not just an endocrine emergency, but also because of the underlying malignancy. So this case was done in conjunction with hematology and oncology. Thank you so much for your time.